Over the last couple of years, the interest in sustainable healthcare has been growing globally, and the transition toward environmentally, economically, and socially viable health systems is perceived as inevitable and necessary. This current panel discussion today would discuss health tech, the evolution and perspective for all stakeholders. Delegates, please put your hands together and welcome the moderator, Dr. Masood Ikram, the Managing Director, Mellon.ai. Along with the panelist, Dr. Balamurali, Spine and Neurosurgeon, Kauvery Hospitals. Mr. Justin Jesudas, the Chief Operating Officer, IIT Madras. And Mr. Mr. Akhilesh Kohli, the Vice President, Head, APAC Global Business Services, Philips. Over to the panel.
Thanks for the warm welcome and the claps, whatever happening here. Dr. Masood here. I'm so privileged to have a beautiful team of experts sitting with me. Hopefully we conduct this right and right time, and right timing is also more important for us. Okay, so we have three important people here from three different backgrounds. We want to have a different perspective on the same topic, which is more interesting. Let me start with Dr. Bala. It's more interesting because first of all, you being here as a doctor and participating itself is a big question. Help us answer that. That is one. And if I have to ask you, 10 years before, now you have been spent 10 years in the industry, where do you see technology has grown? From which perspective? This will help us set a context, context at where we are operating today.
Sure. Thank you. I'm Dr. Balamurali. I'm a spine neurosurgeon from Kauvery Hospital. In terms of medical technology, I've spent a lot of my time in UK and the US for more than 15 years. So I've seen the technology in the other part of the world, and I've been in India now for almost 6 years. The reason why I'm here is that, I think that technology has revolutionized healthcare. There's no doubt about it, but we have still a very long way to go. So technology in healthcare, to answer your question, has really revolutionized in 4 areas. One is pre-hospital care and chronic health. So this is in terms of monitoring a patient's health, whether it is doing with blood tests or weight loss or various other things through software and hardware. The next is diagnostics. So we know that diagnostics is one area that is hugely focused, and one of my colleagues here is going to talk about a lot of that, is how to diagnose a problem accurately and without less effort, with less people, with less human interference, so artificial intelligence and various ways of diagnosing problems. And the next one is procedures and surgeries. So, we use a lot of technology in terms of accuracy, in terms of how we treat the patient and how we do that. And the next most important, which is coming up, is post-operative care and rehabilitation, which again, somebody is here going to highlight on those things as well. So these are the 4 domains in which, medical technology has really grown. Fortunately or unfortunately, India has a lot of technology, but it is more in the urban than in the rural. So we're going to discuss and debate about those things today, and that just sets the context about our discussion today.
Thank you. That's a good perspective. Okay. From a user perspective, let me go to a research perspective. Okay. Justin, you are already popular here. People want to hear you, and we know what you have gone through and what you are building it through also. But I have to ask you very specific on the research aspect here. On the research aspect, you have seen some developments abroad, some developments in India. Research aspect, where do you think India perspective and abroad perspective is currently going on here?
Right. Hi everyone, good evening. I head operations at a research center which is called the TTK Center for Rehabilitation Research and Device Development at IIT Madras. So I'll probably talk about the assistive technology and the rehabilitation technology standpoint. As far as India is concerned, there is quite a big gap. So in terms of assistive technology, WHO says there's a need for about 2 billion devices by 2030, and right now about 1 billion devices that are needed. Unfortunately, out of 10 people who need the device, only one has it. One has access towards it. And in the developing countries, the statistics are even more staggering. So what's really happening is, on one hand, you're looking at very high quality devices, high-tech, for example, exoskeletons, right? Everybody who's paralyzed or at least from a healthcare standpoint, is a big fan of exoskeletons. But if exoskeletons are going to cost about 80 lakhs, 60 lakhs, even the Western country, it's not affordable. Imagine in India, even if you make something for 2 lakhs or something, it's not going to sell because you're talking about probably 100 devices in a year being sold. So there is a huge gap between affordability. All the high quality devices in India have to be imported. And what's available in India are these low quality devices that are outrightly rejected by people. For example, wheelchair. There are about 3 lakh wheelchairs that are sold every year, and about 95% of these are these surgical bought wheelchairs that are not made for mobility. They're made for hospitals, where you take them from the ward to the doctor's room or to the x-ray. So there's a huge gap, at least from rehabilitation technology and assistive technology landscape. There is a lot to be desired. Thank you.
Okay, that's nice. Actually, what I was been reading yesterday, that in 2021 alone, the patents registration for AI itself is like 1,40,000. This is the number in 2021 alone, which was 1 decade before was just hardly few thousands, thing like that. We can see a lot of research work coming in that perspective, which is very nice. So to you, you're coming from the Philips background, you see so much, I think. And then we can see a trend with the number of patents coming up, going like that. You feel challenged in India, or what do you feel? You still have long way to go in India?
Yeah. So hi everyone. So in India, the couple of things which are very different and unique. Today, like Justin also mentioned, 90% plus devices or hardware are which is imported into India because of the nature of the factories available or the research which has been done. So it is a translation of what has been created, keeping in consideration the global environment, and then brought in and imported into India, which is also a good thing. That we can leverage the latest technologies, and I'm sure doctors will vouch for that. But at the same time, the ability of researchers to look at Indian landscape, our diversity, and have something created for India to India, I would say it's still very limited, and that's where the next level of potential needs to be evaluated at least, so that we can further build on the the ecosystem we need to have, whether it's affordability, design, sustainability, and actual usage of the scale which will be required in the coming years. So I would say, I guess translating that into Indian context, will be a long way to go for now.
Long way. Okay, Bala, it's very simple that all the technology today is been built surrounding a doctor's needs. Okay, but you also had one more topic called rehabilitation. Rehabilitation is all about patient's perspective. Now, Justice is on the stage, so I wanted to bring this topic in front of you. On a development aspect, okay, it has to be a rehabilitation perspective. Where do you think India is or development is happening towards?
Yeah, I think it's a very, very important question. If you look at it, the problem that we have, not just in India, throughout the world, is that you have a group of researchers, you have a group of doctors, and you have a group of consumers. So there is a huge difference in the way people look at. The researchers look at, they want to get the best in technology to get it out to the consumer. The doctor feels that this is what my patient wants, this is what the technology wants. But the consumer has a total perspective, which Justin can throw more light on. So there has to be groups which are formed, for example, NASCOM or NASTech. So these are groups that have to have that link between healthcare professionals with researchers and professionals and the end user. So there is still that gap in everywhere in the world. And unless we bridge that gap and all of these people sit under a table and discuss what is it my patient wants and what the patient wants from here, we are never going to progress. So I think that's where the gap lies in. There is technology evolving. As Justin said, there's a huge difference between the Western world and here. And I run a rehabilitation center as well. And I know the difficulties my patients have in terms of affordability. Because even the technology which is there cannot be used by our patient because they don't even come to rehab. There's only 5% of people who have a disability, they come to rehab, and then why are we talking about introducing technology to them?
Justin, you can add something to that probably.
No, that's so true. Let me go a step, even back. Here's a guy who picks up a spinal cord injury or a stroke, right? They spend good amount of their life saving in hospitalization. And then the next step is rehabilitation. They've already spent force. They don't have enough money. In India, unfortunately, insurance does not cover rehabilitation. It's sad. Uh, After they finish the rehabilitation, if at all they get there, 5% if they get there, and then if they need a device or a technology, where is the affordability? Money is not there, no longer. Pockets are not there. Which is why if you look at India, India is a perfect example of a market that has high needs, but the demand is not there. Even if we make a device for, let's say, 5,000 rupees, you're talking about 80% of the population with disability or lower income strata, where they just don't have the money. Even if they're employed, it's in an unorganized sector, or in a, they have their own small business. Their monthly income is probably around 10,000 rupees. So any device that's at 5,000 or 10,000 rupees, 1 month's income. So I think that's the gap that we need to really bridge.
We have seen one popular video coming from IIT. Most of us have seen this in WhatsApp. The wheelchair guy goes in next to the door. He can just, draw something over there. He raises his heights. He can reach to the particular thing, which is very popular everywhere. You think these kind of technologies is what we are working, or are we working way too advanced to solve big problems in the world?
Yeah, so when we started our research center about 8 years back, we made a conscious decision. We are going to cater to the masses to start with. We have to get our, the low-hanging fruits right, so that the low-income group also gets kind of sorted out there. So our first device that we commercialized, so our lab, unlike a lot of other labs, is not just like, an academic lab. It's like where we believe that the project that we're doing has to finally get translated and get into the community. It has to go to the user. It will not just stop as a research project. We were very conscious about that. So the standing wheelchair was the first product that we commercialized about 3 years back. It costs about 15,000 rupees.
Oh.
Yeah, it makes a person paralyzed completely to stand. An equivalent of that in the US or in Western Europe, and 3-4 weeks back I was in the UK, and they were surprised when I said it's 15,000 rupees, which is about 150 pounds. And the devices there are about 10,000 pounds just to make you stand. Right? Simple gas springs, and you can still do it, and it's absolutely safe. And thanks. So I think frugal innovation is possible. Technology with the right people in place, where the healthcare community comes in place, the researchers come in place, and the user comes in place, and the industry comes in place, it's nothing short of magic.
Yeah, so industry plays a bigger part here.
Yeah.
Thank you. Yeah. So to you actually, so in the research perspective itself, to continue forward, how much is Philips investing their time and energy and money in India and abroad? It's 50-50, 90-20. Where does India stand in your research perspective? Yeah.
So see, Philips as a culture, as you know, has been in the innovation space. One of the, cribs I have had always with Philips was, if you want to replace a product by the same product 2 years later, it's not available. They've already evolved and made a new product. Keeping that philosophy in mind, India today is still a very small player in terms of the support in the local market. What we are being leveraged in India essentially is being a hub for doing research and development, both in software and hardware, and being leveraged that for the global market, one. Second, India is being used as a test import base for a lot of global products as the Indian healthcare expands. What we are looking to do is to do one India initiative, where we are saying we have the hardware, software, back-end analytics, AI, as well as the marketing in the front-end India business. How do we come together as a unit, and all these 4 things coming together and start investing into the Indian space? Because Philips has been in India for close to 70 plus years. But it's been more in the commercial space. Now we are looking to innovate and leverage the ecosystem also. Yeah. So early days for us.
Early days.
Very early days.
Very early days. So do you have a good amount of research happening abroad than compared to India?
Yes.
So is it like Indian research happening in India, or is research happening in India is also for the abroad itself?
Mostly the Indian research happening for actually global markets. So still the shift of Indian research for India is still to happen effectively. Yeah.
So their research is still a gap. Okay, companies like Philips or Justin is trying. We are mentioning something like that. we are sitting in ASCOM, we are seeing a lot of startups here. I think it's a motivation for all of us to see that there is still a lot of gaps in healthcare when it comes to research point of view.
Yeah, and yeah, I think the one thing I'll add is that the like what Justin said, affordability, modular sessions. For example, we were talking earlier. You don't need big, huge setups. The nature of the diversity and the need of expanding services has to be beyond the 5-10 metro cities. How do you breed that outreach and create modular systems which will enable accessibility of healthcare to the larger Indian network? And I think that's where the partnership and research needs to happen, and where the doctors can complement what is the best model. Yes. For a pilot, just to add, for a pilot we have a few tie-ups with doing mobile medical healthcare vans created to do some female health services or for children healthcare. But that's a very small segment. And we feel that there's a lot of potential to expand that kind of a mobility services. Yeah.
You want to add, Doctor? You want to add something?
Yeah, sure. See, in India, the way they look at it is they feel technology means cost. So, the urban technology is, hospitals, private hospitals have everything that you need in terms of diagnostics, robotics, AI, everything. But it all comes with a cost. So patients also feel that, they are hesitant to go to some of these hospitals because they think this hospital has high technology, so it's going to be expensive. And we end up with having what we call as vomits. So vomit means victims of medical information technology. So, you people just go in for a back pain, you have a scan, and you find out 10 other things. And then you start going down that path and trying to investigate each and everything. So technology itself in the wrong place, in the wrong hands is also very dangerous. And that is what I see that's happening in urban. So we also need to invest in the right technology which can be used by everybody. It can go to the rural, it can go to the, the furthermost person in India. Because in the urban situation it's totally different. We are even much better than I worked in best hospitals in the world, and Chennai probably has more technology than in any of those hospitals that I worked in. But we don't need that technology. We don't need so much of that technology for our Indian patients because it's not covered by insurance. Many things are not affordable by patients, but we still have it because we have. So the good news to the people here is that there's huge amount of work that needs to be done in terms of getting medical technology to go. I think there are huge gaps. We are focusing more on AI and more fancy things that are there, which probably are something that needs to be done much more abroad. We need to look at more local problems, solutions for local things.
Nice. Thank you, Doctor. That you are giving a perspective saying that there is technology abundantly available, but might not be solving the core problems. That is what you're trying to. If I have to ask you one more question following that, you are practicing every day, thing like that. Okay. So there is something like, there's one or two problem which is there every day with you. So there is a psychology saying that, if you see a same pothole every day, you forget that pothole, you keep moving from the side. So we get used to that particular pothole and go. If you can recollect any one of the problems in your day-to-day life every day. So what we believe is 80-20 rule. Okay. So if I get problem, 80% of a problem, I need to choose the top one or two problems of you. Can you relate any one or two like that?
Yeah, sure. So I think, in two areas where I would look at this problem. One is in human error. So I think, yes, as I said, in my hospital, I'm at Kauvery, we have all the technology. So I'm not worried about the technology. I know that my robot or my machines would fail in probably 1 out of 100 times. But the commonest problem is human error in terms of communication, in terms of getting the information of the patient, in terms of connecting the right patient with the right treatment, getting the right patient to the operation theater. And so, getting the right diagnostics for the right patient in terms of, the lab showing you wrong results and wrong treatments happening. So this is what scares me more. And the commonest cause of death worldwide in healthcare is two things. One is human error and second is drug error. Yeah, so my second common problem is drug error. So there are technologies which need to be evolved that the right patient gets the right dose of drug. What if the patient takes overdose? Is the patient actually compliant? Somebody comes in with diabetes, is he taking the right drugs? Is he taking it properly? So these are some of the, I think these issues, if they are resolved, would make most doctors happy. Because technology is going to evolve, we are going to get more and more robots, and mostly doctors may not have work in another 20, 30 years as well. But the commonest problem is, errors that happen in hospitals due to humans, and there needs to be better softwares and better ways of, tracking and doing this. So I think that's what I feel is important.
It's so surprising to hear that, we have Reliance, we have so many communications talk so big about it, but you're telling your daily problem itself is communication.
Yes.
Okay, that is such a big thing. You put it across. Probably the new people here who are looking for new ideas, I think you should start from the basic problems. We don't think that we have the best communication, the cheapest communication in the world. We do have problem in communication as well. Okay, Jasin, to add to this, something like this, okay. If I have to ask you, you are known for R2D2, okay. So probably most of the people might not have heard what is R2D2 and where is your work going on in R2D2, something like that.
Sure. So R2D2 stands for Rehabilitation Research and Device Development. Our lab is all about researching human movement, the biomechanics of human movement, and also we develop assistive devices and rehabilitation devices that help people with mobility impairment, physical disabilities, and the aging population as well. So basically anything to do with movement and solutions for that, we develop there. We've been in existence for about 8-9 years. We've commercialized 4 devices. One is a standing wheelchair, some of you may have seen the video. Second is a high performance rigid wheelchair, which goes 3 to 5 times faster than your conventional wheelchair. That statistic might be so insignificant, let me translate that for you. So 13 years back when I picked up this disability, a car accident that left me paralyzed neck downwards, I was told, I was in Hyderabad and I was told, go to Nampally and pick up a wheelchair at the surgical shop there. Fast forward 13 years, barring people like Dr. Bala, majority of the doctors still say, go to Nainappan Naikar Thiru in Paris Corner and buy a wheelchair, right? Now that wheelchair, based on the statistic that I already quoted, you push, one push, it goes 1 meter. This wheelchair that I'm sitting on, the wheelchairs that we are developing at our lab, goes to about 5 meters. Which also translates, morning I do my fitness routine by pushing the wheelchair. In that wheelchair I'll do 1 kilometer, in this wheelchair I can do 5 kilometers. Which means I can go faster and I can go further, right? So that device is something that we've developed. Then we thought, okay,
this needs an applause please, yeah.
Thank you. So then we thought, okay, we made the wheelchair for mobility, but if that guy goes in Indian road conditions, the walkways are not accessible. They don't have curb drops like you have it in Europe or in America, and the potholes are making the road uneven. So how would that guy go in a regular wheelchair? So we developed a motorized device that you can clip onto the wheelchair, in the front of the wheelchair, and the wheelchair suddenly becomes a scooter, a roadworthy scooter that can go up to 25 kilometers range with a top speed of 25 kilometers per hour. So that was the third device. And the fourth device was a polycentric knee for knee above amputees. Now, all of these technologies are, in a way, very indigenous. We developed for the first time in India. While we are very proud of that, what we are not probably proud of is, these are some of the things that have existed in the Western world for some time now, right? Like a polycentric knee has been across the globe for about 30 years. In India, before we developed this, what was there was something called hinge joint for the knee, which means once you lock it, your knee doesn't bend. You'll have to hike and walk. You'll have seen, a lot of amputees hiking and walking. What we developed, you can even sit in cramped spaces like autos and buses with a flexion or folding of 160 degrees. So these 4 we've already developed out there in the market. We've licensed it to the manufacturers so that they can take it to the globe. We've talked a lot of challenges, but here's the solution, right? We operate in a model called grid model, which is well coded in rehabilitation technologies and assistive technology space. G stands for grants. We raise government grants or CSR grants. We put that for our research. R stands for research. As a nodal organization, a research institute, we do the research by ourselves or partner with other organizations, could be CMC Vellore or any other university across the globe. We partner with them. I stands for industry, which means any research that we develop, we identify an industry partner, which could be an established industry player or a big player or a startup. We translate, we license it to them, and then D stands for dissemination. Now, you can do all of these 3 things, but if the user does not have the awareness or the clinician does not have the awareness, it all falls flat. So in the last 1 year, we've trained about 1,500 occupational therapists, rehabilitation therapists, because fundamentally in India, you can't get a specs without prescription, but you can get a wheelchair without a prescription, right? So we wanted to change that narrative. Assistive devices should be prescribed. It can't just go out there. So that's the model that we worked on. In the future, we are working on some of the futuristic devices. These are all conventional assistive devices. We're also working on hand neuro rehabilitation device, arm neuro rehabilitation device for people with spinal cord injury, stroke, with gamification and all that stuff. We're also working on smart devices to enable wheelchairs where you can haptically control them. Because we were talking in the lounge, for about 20 years, the technology of motorized wheelchair has been there. But how do you control it? With the joystick. It has not changed at all. The person is already disabled, and you're asking that person to use one hand on the joystick all the time. So we thought, there are cruise controls in the car. Why can't we have different technologies to control a wheelchair? So we're working on those kind of technologies as well.
Akhilesh, it is, yeah, there was some goosebumps there. Akhilesh, this is something very simple question, but it makes a lot of sense to the audience here. There are so many technologies, okay? We talk about AI, we talk about nano, we talk about soft scale, hard scale, things like that. In your angle, in the Philips angle, which is the top priority you give today? Is it AI or nano? Or where does it stand?
So the top priority, I would say, one is starting with, for the existing technologies, AI for two reasons. One, to figure out a way to integrate the patient data for enhancing the care. The problem, I think doctor just mentioned, it resonated very well, because you've heard of computers like IBM Blue, where you are trying to get as much as patient data and also diagnostics available, and say, how do you take this informatics and enable that? So from a current stage of evolution, I would say that is one area the teams are working on. The other area which is very important for Philips in the healthcare space is, today if you go to a hospital, both from a basic energy consumption, the electricity bills of the hospitals compound for at least 15% of the hospital costs. They're all huge guzzlers of electricity. And second, the usage of getting a patient to get an X-ray or an MRI is very cumbersome still. It's not evolved a lot. So the other thing is about how do you make these technologies doctor and patient friendly, so that doctor can focus more on the patient care rather than facilitating with the support, because otherwise the hospitals have a huge cost of getting the additional support of making sure the patient is put right and all of that assistance, and less on actual diagnostics. So that's the other area we're saying, how do you make the experience seamless and a sustainable way, which are something people are scared, like kids. You see a lot of specialty children hospitals. Kids are scared to go through an MRI because the experience is very difficult, cumbersome. How do you make that experience outrage? And the third is, every technology company, hardware company is looking and saying, how do we make outpatient facilities much more accessible? Because everybody cannot come to metro cities and get treatments in big hospitals, and how do you get that modular model? So these are the three focus areas in technology, which I think will go a long way. And the key thing which will bind it together, like I think doctor mentioned earlier as well, how do you get patient, manufacturer, doctors and technologists together in a ecosystem which says, guys, sit together, solve for it for a real problem, not a fancy problem. That's the way I would say it.
Nicely put up. So it's basically the AI comes first, and the user interface and reachability. These are the things. When you see the chart of AI development throughout the world, the top 5 countries who are invested and working heavily, the top 5, I don't want to mention what are the top 5. Unfortunately, India is not in the top 5, which is not a good way. And we are looking in for AI development, thing like that. In spite of my previous statement, I told 1.4 lakh patency has been this thing, but unfortunately, India is not there in the top 5. So there is something, a gap. The industry is telling we want AI. The research is telling AI is required. We all talk about AI, but unfortunately, India is not there. And what comes first in the list is China. So I think we should be real careful and work towards something towards that, and look for something much better coming out of here. Doctor, hear me out, okay? What happens, generally we advise doctors these days, you do paper publications. You must have done a lot of paper publications. The process of a paper publication is very simple. You collect the data, you take an extract out of it, and you publish it, okay?
these days we are talking, you can publish that particular data, whatever you have, but why don't you convert the data, use the data and make an application out of it? For example, you would have picked up something. So we want the data to be flowing in a manner at which helps all the other people. So here if you could talk about AI, the challenge is data basically. So what is it that, hindering a doctor's perspective, why we are not able to give a right amount of data to researchers?
Yeah. So I think your question has the answer. You said perfectly rightly that why is India not in the forefront in AI? For AI, the most important thing I understand is data. So the problem in India is two things. One is you have not enough people to collect data. And two is people don't rely on Indian data because they think that, data is fabricated. If I go to some conference and I present saying that, I've done 1,000 of these kind of tumor surgeries in the spine or brain, and people have said, wow, but why haven't you not published it all this while? I don't have a people and team to sit down and collect that data, analyze my patient's lost to follow up, they never come for appointments, I don't know what happens to him, where he goes, I don't have any of that data. So our problem is going to be is that we are investing more in technology, and as I said, we need to invest in more human resources. So we do not have enough human resources to collect data, and that is the problem why the publications, if you look worldwide, though India, China would be, due to our population, we do huge volumes of diseases and conditions, we do not have accurate data. The data that you can get accurately is what devices can pick up. You do diagnostics, you can take up data from blood tests and things like that, but if you actually want to look at more specific data of disease, conditions and problems, there is no national registry for anything. If you ask Justin or anybody else who is in the spinal cord injury forums, nobody knows how many patients in India get spinal cord injury. Nobody knows how many patients in India have stroke. Nobody knows anything about any data. So if you don't have data, what are we working towards? What are we trying to devise? Where is our technology going? Where do you focus our technology? And we don't know. So I think, this is something that, forums, governments have to work towards collecting data first, and only then AI would really become the forefront. So I think that's going to be the biggest challenge.
We need more resource to collect data itself.
Yes, we need resources, methods, whether it is softwares or, tools where data is easily captured and data is analyzed by, people. Because, in the corporate world, people really, unless you're doing research or a research institution, nobody's worried about data. The data is more on financial terms rather than clinical terms. Research institutions and hospitals like government hospitals with 1,000, 2,000 beds, they have huge volumes, but they don't have any data. Because there's nobody there. There's enough work for us to do clinical work. We don't have time to sit and write papers and collect data. So my publications, which was like 100% when I was in the UK, is about 20% now. Because I don't have time and I don't have complete data.
Thank you, Doctor. I have one last question to Justin, and probably I'll open up for more discussion. We want more healthy discussions here. Justin, I am also a startup NASCOM in my previous days, and I've been the journey coming from the other side. Probably today I'm sitting here. I want to ask you one thing very clearly here. Okay, the research happens. Okay, there are two ways to see a research. One is one angle is this is my problem. What is the research? Other angle is I have an idea. What could be the fitment for it? So there is a two-way. So what do you think is today's angle of people looking into it, and what do you advise on this particular thing?
Yeah, I think that's a great question, and we see this almost every day. So we are a lab which has a lot of PhD scholars, postdocs, engineers, and oftentimes what happens is, oh, I have this idea, I have the solution. And I go like, okay, what's the problem? And they'd be like, who's the user? I don't know, but I have this problem, right? Fixation. As part of design thinking, we have this concept called fixation. Engineers often get fixated with the idea. Researchers get fixated with an idea, and they refuse to actually find out what the problem is and who the stakeholder is. So one of the things that we do is, in fact, in our entire project plan, we ask them to spend about 3 months to identify the problem and frame the problem statement. We ask them to go, and we tell them, don't rely on surveys. It's pointless. Just getting numbers or data, it's not going to help. Go and live a day in the person's life so that you actually know what the challenge is really. Then come frame all of it and then go into conceptualization. So yes, majority of the times we find solutions coming first, then trying to fit into the problem, which is why a lot of devices are forced on people. You don't even need them, but it's still forced on them. I think we should take a step back, and if we start understanding what the problem is, a lot of solutions are going to be simpler, the time spent on R&D is going to be lesser, and therefore the cost of R&D is going to be lesser, and it's a chain. And then, you know, you suddenly start finding out, oh, okay, there is a simpler way of doing this. I think, you know, I think if we start embracing design thinking, user-centric designs, devices would be better, the world would be a better place.
That's nice. So you have also mentioned about the importance of an idea. You, Akhilesh, you have mentioned, you know, let's go to a room, sit down, you know, bring something out the ground. You almost said it, you know, please come and listen to me, I have problems. So there is a clear statement coming out of here saying that, you know, there are still problems, technologies are not enough. And we are ready to do it, who is going to do it? So there is a bit of understanding issue. Probably if you could able to relay here, you know, how to approach a problem and how the technology can come out of it, probably it would be a good win.
Yeah, if I may just add one sentence. So the standing wheelchair that I spoke about, the first prototype when the engineers made, and at that point I was a power user for them, I said this is nonsense. We learned from a mistake hard way, and we are happy to acknowledge our mistake. Which is why after that in the design journey, the engineering team sat with 250 potential users. 250 people with stroke, spinal cord injury and you know, disabilities who actually want to stand. And that's why we were able to develop a device which is exactly what a person needs, and the demand for it is also high.
That's nice. But Justin, I would like you to mention the same thing what you told me off the stage. So they are building some particular place which is, you know, you go and experience how a handicapped guy is going to. Can you please put that to people?
We are developing a center called National Center for Assistive Health Technologies. ICMR is funding that, and we are building that in the research park, IITM Research Park, IIT Madras Research Park. And often when I give speeches and sessions, I ask this question to people, right? Imagine if the world's population, 90% of the population are wheelchair users, right? We'd be building the world basically, and you all would be minority. Then the ceiling height is not going to be beyond this, which means people without disability, the 10% of the population, you would all be crawling inside. Such a disabling experience, right? That is exactly how the world is for persons with disability. Because 90% of you without disability have built this world, and you built the way you wanted it, without being inclusive or without being universal. And therefore, it's so disabling for us. So we're developing this experience center where there'd be enabling zones and disabling zones. You'd be going through all of this, and when you come out of it, you'll realize, oh, we could have done a better job. We could have built the world in a better way. Right? Thank you.
Thank you. We have time up actually, but if you have a quick question, anyone, we can take it forward. I think, yeah, Dr. Wasim has a question there. Yeah. Go ahead, I can relay it from here.
Thank you. Hi, I'm Dr. Wasim. I practice preventive wellness and longevity, an area that is ripe for AI and technology, and that's something a lot of disruption is happening. So actually for the entire panelists, do you see how this preventive medicine is now becoming very, very important and as a way to make it more accessible than getting it to sick care? And the second question specifically to Dr. Balamurali is, sir, throughout the UK last year, about 100,000 physicians left the profession. And in the US, it's bordering between 70 and 80,000 a year. So the physician fatigue is a real problem. And sometimes they believe that this technology is actually worsening that rather than making it better. And people say that in the US, and with my very brief time there with plastic surgery, the amount of time that a physician spends in documentation is extremely high. Do you think going forward that problem is going to come down to India? And secondly, is technology solving that, or is it also making it better here? Are we learning the wrong things from the West? Those two questions.
Sure. I'll probably answer your second question first. Yes, as you said, you know, documentation, identifying the problem, and at the same time creating database takes a lot of time for healthcare professionals, both nurses and doctors. And in the abroad, you know, everything is become paperless. and from your operation notes to everything is paperless, and there's no papers anywhere. Now the question is, if you create such a system in India, yes, you can make it paperless. There are quite a lot of hospitals in India who are paperless with documentation, but who's going to look at that data? See, if you take a UK where you have been, and I've been in UK for 15 years, everything if you go anywhere in the country, you can pull up a patient's data. Yeah, you go to London or you go to Edinburgh, you can pull up the patient's data. In India, you go from one hospital to the next door hospital, nobody has your data. You only have to carry your data. If you lose your data, then your data is gone. So I think technology is going to help in terms of this, but how that gets integrated into the entire ecosystem of healthcare, where the GP, a doctor, the patient, the consumer, the industry, what information they need to get, they should be able to get. And that is when it's going to get better. Yes, these are some mistakes done abroad, but I think in terms of documentation, I think this will really benefit India, because this is going to be something the way forward. The first question, probably anybody else wants to answer? Your first question was, sorry, if you can just say that again.
Yeah, my first question was, prevention is now
Yes.
being the space for ripe
Yes.
for disruption.
So the prevention space is going to get bigger. Now, I think the most biggest software is Healthify Me or any other of the weight loss programs or the diet and things. But there is no, there is no human connection in these things. I've downloaded some of these apps, and I've developed an app as well called Get Fit 360. Here, we cannot rely on these kind of softwares in terms of prevention unless you are monitored by the right people. It is all becoming very commercial, and I don't believe in this, and I don't think this is how technology should grow. I think the technology should grow where you have a doctor or a paramedic or a nurse who knows what they are doing to be involved in your care, rather than you just go pay a few dollars, download a software, and just keep doing what it says. So I don't think that technology should be used in that way. And that is how I look at it. Because it's not that doctors and hospitals need work. We are overwhelmed with work. We don't want to see some of these things, but I think we need to focus more on prevention, which is what the Western world is doing, than treatment and diagnostics. We are focusing more on diagnostics and treatment. You want to go to the community and prevent diabetes, prevent cholesterol, prevent blood pressure, so you don't come to hospital with a heart attack or a stroke. You want to prevent road accidents so you don't have road accidents and people on wheelchairs. So I think we need to be focusing our technology on preventive healthcare, but that needs to be done in the right way. But I think in India it's taking a wrong turn.
True. Post-COVID, the importance of wellness has gone up, healthcare has gone up. Unfortunately, the definition of wellness itself is taken in the wrong perspective. People use wellness to sell products, but actual wellness is very different. If I have to take a separate session on that, so let's not touch that. I think any other last question? Anything? Or close it? I've already been given red flag. Yeah, one quick, ma'am, yes, please.
Good evening, everyone. See, actually, in the initially, I've said that data has to be collected in case if you want to innovate.
Please state your name and question to ma'am.
Myself, Nalini.
Only question two?
Yeah, you said the data has to be collected, more member has to be added to the collection of data, right? So in other countries like UK, USA, they do have a centralized system for healthcare data. So whenever in other state, if it's someone met an accident, they do have a centralized data system to collect the data. Even with the other hospital data also they accept, and they do start with the procedure from there. But in India, we don't have, right? So the hospitals don't accept the data from other hospitals. So how can we, how can we implement this?
Very nice. I can answer this. So there's something called central repository of data, and there's something in health card, and all the data, again, we might talk good or bad about Qatar, which is going on today. There last year, they have a beautiful system called a health card. Okay, you are a private hospital, you are a government hospital, whatever you are, better put all the data in there. India is in a path towards that anyways. After the Aadhaar number, we'll have our own health number, and every information of mine, yours, everything should go to that particular number, and you can give access to anybody to that level. Okay. Look at the amount of people in India, the population in India. To drive this to across the people, it takes its time and thing. We are on it. We are on it. Probably we should be able to get that into it. Thank you so much. Thank you, everybody. Thanks for all the gentlemen on stage. And thanks to these two gentlemen standing here, especially this lady doing a lot of hard work here.
Thanks to the panel members and to the moderator. I now request
Thank you, sir.